We had that problem in the hospital where we would send people home and they wouldn't have a really clear plan of what to do for their wounds, and they would end up back in, and we'd say, what happened? They said, my physician took one look at my wound and sent me back in here. So again, we want to empower patients. We want to have a plan for all of them going home. You wouldn't send someone home who needed diabetes care or wound care or any sort of care where they needed to give themselves injections without teaching them how. However, when people go home with wounds, they tend to just send them home. Unfortunate. So no financial disclosure for either of us, sad to say. And we identified hospital-acquired, and hospital to community problems when we were transitioning care. So we wanted to find a way to be able to have a plan of care for patients, the patient to know the plan of care, and to do a warm handoff. Because that's the biggest problem. We weren't handing off to anyone. They're just out there as ectoplasm until they go to the next place. So we've done this study on best practices for pressure injury treatment and prevention in hospital. And our big focus was pressure injuries because we were able to count them. So this is our NDNQI. I don't know if you guys know the National Nursing Data Quality Indicators that you have to collect within a hospital at all times. So this would show you how many patients had developed pressure ulcers in the hospital. So if you developed a pressure injury or a pressure ulcer in the hospital, that was less than 1% of our patients. However, all the money goes to that. So if you're, trying to prevent pressure ulcers in the community, or you're trying to prevent pressure ulcers for people like, oh, this person had a stroke, we need to make sure they have resources going home, no money goes to that. All the money goes to prevention in hospital. And when you look at the numbers, less than 1% of people develop pressure ulcers in a hospital, and we were getting 6 to 8% coming into the hospital with pressure injuries. We said there's something very off here. So we looked at the community-acquired pressure ulcers as compared to the hospital-acquired pressure ulcers. And this is just 1 year. Before COVID, we looked at 821 patients came into the hospital in 1 year. That's separate patients. That's not how many times they came in. 821 patients, and only 45 patients developed hospital-acquired pressure ulcers. And we are talking about stage 1 and 2s. Most of those were stage 1 and 2s. And you can see that for coming in from community-acquired pressure ulcers, 566. So most of them were high risk people who had very deep pressure ulcers coming from home. And the funny thing about this was, in my mind, my evil mind, I'm thinking, it's those nursing homes. They're sending everyone on the weekend with these bad pressure ulcers because they don't want to look after them. Okay, I was wrong. I was completely wrong, because at the next study, I'm going to show you this. So when we looked at the total again, we said, let's see how many are coming from home and how many are coming from skilled nursing or long-term care. When we looked at them, more than twice the number of people were coming from home. And then we looked at the number of times they were admitted. They came in from home, they were admitted many more times. We had one patient, and she was admitted 25 times in 1 year. You're like, how did she go home? She was there for a week or 2 weeks. She had a chronic pressure ulcer 25 times, and we counted it up. She was like the top spend in the entire hospital because she'd been admitted so many times. But she would come in, she had an ugly wound, and she was admitted through the ED every time. So it's really important to know where they originated, what could we have done if we had treated this differently in the first place. So this is something that we run through the hospital. This is a filter that they can put on, and they can give you the numbers. So we have what we call at UCD multi-visit patients. So a multi-visit patient is a patient who has 4 or more admissions in a year, or a patient who has more than 10 ED visits. And we have, and we know that those patients spend about, I think they spend about 80% of the funds of the hospital, that group. So when we looked at that group, we said, this is a day report. We have 849 patients within the UC Davis system that are considered MVPs. How many of those in the hospital today? So on that day, 66 patients were in the hospital who were considered MVPs. And then I then looked into them, and I found out of those, 11 or 12 of them were chronic wound patients. Most of them pressure ulcers. So again, if you have the numbers, I say measure what you treasure. You have the numbers, make sure you report those regularly, track them, and report them regularly to your administration so you can get funding. So again, here's that hospital-acquired, or that community-acquired pressure ulcers. Home versus skilled nursing facility. So we wanted to look and see what was with these patients. So we had, again, more than twice as many coming from home than came from skilled nursing facilities. And then I wanted to see what was wrong with these people. What were they brought in with? What were their primary, because if they had a pressure ulcer, they had something else going on. So when you look at it, the younger people, it was younger people with paras and quads, and that was like about 100. In the para and quad, if you look at 28%, younger people, mostly young men of color. You can see we had a lot of neuro, and the neuro ones were considered people who had dementia, any sort of Parkinson's, anything like that. And we had quite a few there too. But when you look at the SNF side, and you know, when you work in acute care, everything is SNF. If it's an outside hospital, you know, acute care, long-term care, whatever, it's a SNF. So that's why we put them in that group. You can see we had much fewer paras and quads, and most of ours were neuro, which makes sense. They go to a nursing home. It's usually they're older. It's Parkinson's, it's dementia, it's other things. A lot of dialysis patients. Cardiovascular, again, I was kind of surprised about that. But you look at the end-of-life stuff, and I only included the end-of-life when the physician wrote in there, this patient's here for end-of-life care. So it wasn't the people who came in and died right away, but we did count those in the deaths. So you look, if you're immobile enough to get a pressure injury, 23% of those are going to die at home within a year. This was the year. And at 28% coming from SNFs. So again, immobility kills people. Not only does it give them pressure injuries, but it kills them. And we found, again, there were more men than women. The length of stay was much longer for the people who came in from home than from SNFs, because the SNFs will usually take them back. And they're giving really good care in these places. And again, it was my evil mind thinking they're trying to get rid of them on the weekends. This is the study we published on that back before COVID, just to say, like, there's a lot of people coming back to care, to an acute care hospital, who have pressure injuries, and, you know, they're happening at home. But we were hoping this would change people's behavior, and when people came in and were admitted, and we knew that they have an increased risk, all those things that I was saying earlier, we don't do anything about it now. We'd like them to do something about it. So again, SNF versus home, you can see the number of admissions. So 77% of those people who had more than 2 admissions in a year were, again, coming from home and not from nursing homes. So they're doing something right. You guys are doing, everyone's doing something right. What are the best practices, again, for prevention at discharge and avoid that 30-day readmission is to make sure that you know what you're dealing with. We wrote another article because we found that physicians like to call everything a pressure injury. So we wrote an article about pressure ulcer, pressure injuries, and what did the National Pressure Injury Advisory Panel do? They just gave it a new name. They went, instead of advancing the science and helping us to be able to deal with this population and this problem, they just changed the name and confused people. And, you know, we went from having no lawsuits in, 4 years to having 2 within 6 months after they called it, but they changed the name from a pressure ulcer to a pressure injury. And again, patients are like, who injured me? Because it just they had that sentiment that must be at. We're dealing with people who have challenges with anatomy now. And you can tell, like, because of their anatomy, and this is a 66-year-old female who's been in several times, you can see she has this pannus and it's hanging down. There were wounds on that, and they wanted to call those pressure ulcers. They weren't. They were a combination of other things. And we have a lot of patients, I was saying earlier, on anticoagulants now. How many patients do we have that are on anticoagulants, and they get, not only do they get wounds, but it's a really long time for them to heal. Here's one again that they called a pressure ulcer, and this is actually a patient who had a necrosis from Coumadin. because if she's been on Coumadin, she came in, she's got this big wound, and they said, oh, that's a pressure ulcer. No, make sure we have the right diagnosis, because if you don't, it's going to come back and say that, nurses caused it. That injury must have been caused by poor nursing care.